I'd like to introduce our morning speaker here, Thomas McAuliffe. He joined the Missouri Foundation for Health in 2005 after serving as the Government Relations Associate for United Way of Greater St. Louis. As a policy analyst, he is responsible for coordinating and communicating about Missouri Foundation for Health's work related to health policy, research, evaluation, and analysis. He has a master's degree in political science from Purdue University and is currently pursuing his doctorate in public administration and political science. He has also served as a lecturer at Webster University in St. Louis.
So just a couple things. First of all, I'm no longer pursuing my doctorate. My wife and I had triplets, and that was 8 years ago, and that's the last word I wrote on that dissertation. So that probably should be excised from the record. Second is that for some reason I woke up on Monday deciding I was going to give up coffee this week. And on usually the fourth day of giving up coffee, I want to roll up in a ball and not leave the house. And today is the fourth day. So if you don't like me as a speaker, just blame it on the coffee. I listened to the previous speaker, and I'll have to say that I'm a little daunted because his speaking style is more the style I like to do, more this freewheeling kind of talking style, and he did it better. So please, again, forgive me if it isn't all that you would like. I'm here to talk about the Medicaid expansion, and I'll just cut right to the chase. Right to the chase. Is Medicaid expansion going to happen in this legislative session? Is it going to happen? That's the number one question the Missouri Foundation for Health gets when we do these presentations. And the answer is that if anyone tells you that they know that Medicaid expansion is or isn't going to happen, they don't know what they're talking about. Because Medicaid expansion, what we think may or may not happen at this moment, will change greatly by the time we get to the end of session in May. There is one thing that can be true, and it's a variation of Wayne Gretzky, that Wayne Gretzky said he missed every shot he didn't take. We will not pass Medicaid expansion in this state, or any, just to be nonpartisan, or any such legislation of that kind without everyone in this room making a phone call to their legislator to tell them why Medicaid expansion is important. Medicaid expansion does lots of things, and I'll touch on them a little bit in the slide presentation, but you have to call your legislator and tell them why this policy is important, and then you have to call them again, and then you have to convince everyone you know to call them. When you think about local politics, you think about state politics, elections are won in tens, maybe hundreds of votes, not thousands or millions. So when you call, your impact is exponential. If you say, think about this. The other thing I'll tell you is that Medicaid expansion is not passed for the last two legislative sessions. One of the lessons of state and local politics is when people from a district call and they apply the levers of power, things do change. So if you are making a phone call, it's worth twice that a lobbyist or an advocate makes in Jefferson City. If you call from your zip code, from your home, and have your family do that, you will help move the needle for any such policy, such as Medicaid expansion. I'm dancing around this because the Missouri Foundation for Health is nonpartisan. We don't necessarily support Medicaid expansion per se. We support what Medicaid expansion would do for the population that we serve. That is the underserved, the underinsured, and the uninsured. But Medicaid expansion as a policy example could be something that you made a phone call, you have friends make phone calls, and you do not let up the pressure in district, in your home district. That said, let's talk about the impact in the Affordable Care Act. Just as a brief overview, this is what the Affordable Care Act did. It created new consumer protections, it improved quality, which we just heard a lot, and costs, and it improved or aims to improve access to health care. There's a big question mark. Will it improve access to health care? Probably not. in the fact that we don't have the workforce at this point to meet the needs of all of the uninsured, and more so the underinsured. But as the previous speaker pointed to, as we move people out of the emergency room and into primary care, there will be improved at nodes of access, but our system has to change to do so. You can see on the one side all the benefits. I just put this up as guideposts to what the Affordable Care Act did. Now, what was it really about? The Affordable Care Act is really about expanding health insurance coverage. It is about getting more people insurance. It should be no surprise that the day after the Affordable Care Act was passed, that insurance stocks went up. There is another class of stock that went up on that day. Does anyone know what it was? It was pharmaceutical companies. They went up. And the idea being that there was a report not so long ago that was put out by the Institute of Medicine and said that American cohorts are failing compared to 12 other cohort states or countries in delivering care, in preventive care. There were about 10 or 12 categories, and we were failing on all of them except one. Does anyone want to venture a guess what the one category that we excelled every other cohort nation, and I'm talking Japan, Europe, parts of Asia. Number one, we exceeded them almost by 1.5%, or 1.5 times. Anyone? Blood pressure. We diagnose high blood pressure better than any other country in the world. Pharmaceutical companies recognize this, and the Affordable Care Act, getting people to primary care doctors, knows that there will be earlier prescriptions for chronic conditions, and people will live longer on more pharmaceuticals, and that's a good business model. That's a cynical way of saying good people, lots of people will have more access to care because they will have insurance. If you buy the dictum that health insurance equals access. We know that is not always the case. It also focuses on population health. This law focuses on improving the health of Americans. Now, it does it in various ways, but the number one way is getting people not to visit the emergency room. The second way is helping people not acquire chronic conditions. 80% of all the costs in our healthcare system come from people who have one or more chronic conditions. Chronic conditions can be prevented, they can be better managed, and there can be money to be saved. Well, how do you do that? You get people to the doctor earlier, you get them to doctors who have best practices, and you arrest the cost of chronic conditions. There is also a new business as usual is over, that is, fee-for-service has to change, and that plays itself out a little bit on what we were talking about earlier, models of care, how they're delivered, and how hospitals and providers are paid for. And finally, insurance regulations changed, the number one being no longer charging or excluding people on the basis of pre-existing conditions. Now, I've given this presentation or a variation of this presentation 275 times over the last 2 years. And usually my best line is, do you know who benefited most from no longer having pre-existing conditions? And the answer is women. Until 2010, being a woman was the most expensive pre-existing condition in many ways because women were charged more for health insurance. The good news is women are not charged more. The bad news is men are. It's not like they dropped men down to the other way around. They just increased men to women's rates. And that's all actuarial value, but the upside is we don't charge on pre-existing conditions. Now, show you here, you can see the costs as a result of changes, percentage change in per capita cost of health care. It has gone down since 2010, or since 2008, 2009, and it's been pretty much a flat line. What we're expecting to see with the Affordable Care Act is some arresting of this even further. What is an interesting kind of variable that we have to counter into this is last year, the baby boomers for the first time began to retire. And if you look at some of the data related to baby boomers retiring, they're retiring with less money than the previous generation, and they are going to live anywhere from 15 to 20 years longer than the previous generation. So we are going to have people who have less money living longer. And this is going to contribute to costs in the system. Now, when you say to yourself, okay, so what has the Affordable Care Act done to the cost of health insurance? And here's the interesting thing is that the cost of health insurance, on average, premiums is going to go up 7% this year. Now, you can see various states have various differences. We are guessing on Missouri right now because insurance companies don't have to be transparent about the increases of their prices in Missouri. But we're gathering that the trend is Missouri will look at about a 7% plus or minus certain decimal points of an increase. Now you say, what does that mean? Well, here's an example. In 2008, the average went up 10%. In 2009, it was 10.8. In 2010, it was 11.7. So we're looking at an average of 7% compared to an 11.7. That is significant. Now, again, it's important to note that in some states, the increases have been very low, and in some states, they have been very high. It's an average of 7%. Now, what did the Affordable Care Act do? It expanded coverage to millions of Americans. At the time that it was passed, there were 48 million Americans who did not have health insurance, about 800,000 Missourians who did not have health insurance. About 13% of our population did not have health insurance. The ACA provided two mechanisms, the health insurance marketplace, or exchanges, I'll use those interchangeably, and Medicaid expansion, which our state did not do. An estimated 25 million of the 38 million, 25 to 35 million of the 48 million gained insurance through the Affordable Care Act. Now, the marketplaces, you may have heard of them. October 1st, they came out last year, and they were a train wreck. They did not work well. I can't guarantee you that they will work better this year, but they will work better this year because there is a year's worth of learning going into their workage. There is also a year's worth of experience that goes into navigators and consumer assisters into helping people purchase insurance. The important thing to know about what these marketplaces do is they allow for the comparison of prices. Never before have we been able to look at an insurance package without filling some sort of form out or giving a medical history and compare prices. Comparing prices, according to the economic model, assumes that people will be able to choose the best plan or the plan that fits them most. Well, the interesting thing about this in the marketplace was we suspected this would be true, we learned that health literacy is a huge component. But even a subset of health literacy, health insurance literacy. Most of us who have been uninsured don't know how to purchase insurance. And those of us who have been insured, 60 to 70% of us get it through our employers. We don't know how to purchase insurance either. So we are asking people to go to a marketplace and purchase insurance without a lot of experience doing so. The Missouri Foundation for Health has put a lot of money into, but there is still a huge gap in health insurance literacy and how to go about purchasing insurance. Now, you can go to healthcare.gov. You'll see it's the website at the bottom, and that is where you actually go to purchase insurance and go to choose your packages. You can also go to covermissouri.org, and covermissouri.org is the Missouri Foundation for Health's website, and we have FAQs and fact sheets and things that are aimed at increasing health insurance literacy. It's important to note that next year the open enrollment period is November 15th through February 15th. So yesterday I was at a cafe in town, and the server said, what do you do for a living? And I said, I talk about healthcare. And she goes, well, my brother went to healthcare.gov yesterday, and he couldn't get anything. And I said, well, tell your brother to go on November 15th, because then all the updated information will be there. Upside is that on November 15th, we're hearing that the number of insurers participating in the marketplace will go from 4 to 8. We are going to probably double the number of insurers participating. in the marketplace, which allows for greater competition and hopefully will drive down some of the premiums as we go forward. But again, and we heard this last year, the problem is not the number of insurers per se. It's the networks that the insurers use or avail the purchaser of. That does not change. Healthcare.gov has not made it easier. You still have to go to the website of the insurance company to see what their networks are. And that's another case in which health insurance literacy becomes very important, because understanding in-network and out-of-network is a huge, huge contributor to medical debt. Most of the medical debt in America comes from people, let me rephrase that, most of the medical debt that goes to people who are insured comes from people who are going out of network and are surprised at how much they have to pay as a result of being out of network. Missouri is unique. Prop E prohibited the state from really promoting the marketplaces. It was a ballot initiative that passed and prohibited the state from doing much. So really, our CEO likes to talk about the ACA as democracy in 50 states. It's a real democratic model because every state has a different approach to the ACA. Missouri's approach has been very much an ostrich approach. We've put our head in the sand. If you go out to Oregon or California, you will hear commercials on the radio saying, go to the marketplace, it's a great place to be, you can purchase insurance. You'll hear none of that in Missouri, for the most part. In some marketplaces you will, and that's the result of some MFH monies. We've worked hard to promote this. But our state has essentially tied one hand behind the back when it comes to implementing the Affordable Care Act. Now, we still have CACs and navigators. They will still be throughout the state. You can still go to healthcare.gov and get a zip code locator as to where you can purchase insurance and have someone at no cost help you. Many of the private insurers in Missouri have also gotten on board, and they're selling insurance through the marketplaces. So this is this kind of interesting synergy where we have public and private working to sell packages. We have a coalition. We've worked hard. It's a 560-member coalition. We meet on a monthly basis, and we have worked hard to improve access to and information about the marketplace. So what does the marketplace look like? Last year, contrary to what the federal government thought, we exceeded expectations by 29%. The marketplace in Missouri enrolled 152,000 individuals. 85% of them received some sort of assistance in the form of a premium assistance and or a copay assistance. 63% chose a silver plan, which shouldn't be surprising because the subsidies go along with purchasing a silver plan. So most people would purchase a silver plan because they get the most subsidy to do so. 30% are between the ages of 18 and 34, 55% are female, and 45% are male. The interesting thing to note is the second to last bullet point, 30% are between 18 and 34. As you know, and I didn't come up with this term, people who are near elderly, those who are 55 to 64, cost the most. And one of the things the Affordable Care Act did was limited. It bound how much the 55 to 64-year-old crowd could pay, but increased the prices of the 18 to 30-year-old crowd, because the assumption is that those individuals don't use health insurance, don't use health care per se. So the federal government projects that somewhere between 32 and 35% of all people in the marketplace need to be between 18 and 32 to make it viable. That is, people purchasing insurance and not using health care. Ours is at 30%, which is not worrying, but it suggests that as we move forward, more young people need to purchase insurance to make our marketplaces as vibrant as possible. The more that we can move this number up, the more likelihood it is that we will have more insurers wanting to participate because they'll make more profit selling insurance to people who don't use it. But in end, the marketplace in Missouri, for the lack of public announcement, for the lack of state involvement, And for the limited number of places to get enrolled, right, that is just from a state perspective, not from the Missouri Foundation for Health perspective, we did a bang-up job, and lots of individuals enrolled and have insurance. There are two things to note here. One, African Americans and Latinos still did not enroll in big numbers, and these are populations that really there needs to be a lot of outreach. And two, as we move forward, we need to think about the marketplace becoming easier to access and for people to understand how to purchase insurance. Now, taking stock enrollment, I just pointed to that. Here's some figures on people purchasing insurance. 61% of adults paying premiums for health insurance purchased through the Affordable Care Act are generally happy or say they can afford what they purchased. Then if you go down, people are generally happy with their plans. 68% of Americans with marketplace health plans rate them as good, very good, or excellent. I would just put a little star next to this. We're hearing from lots of people that they're really happy to have insurance, and they don't mind the premiums, and they don't even mind the copays, but they are really upset over the deductibles. And lots of people are struggling with the deductibles. So as we move forward, I would love to see what this chart or this survey says once people realize how much they have to pay in regards to the deductible. 70% of the people with marketplace plans say they are confident they can afford the care they need. And you can see generally there's pretty strong support for what the insurance plans look like. Now, there is some desire for more choices, and there is a desire, I suspect, as we move forward for deductible. So, Medicaid expansion. The Medicaid expansion, which you came here to hear me for us all talk about, Medicaid expansion was left up to our state. Our state for the last two sessions has debated it, has talked about it. Some say last session we came very close to getting it, but the end result is we did not expand Medicaid. Supreme Court gives every state that right. It's important to know that the federal government pays for 100% of the expansion through 2016, and then it steps down to 90% in perpetuity. So here are the other states. You can see the other states in blue that have not expanded Medicaid. The interesting thing is I was at a talk last week, and this gentleman put a slide up there, and it was this slide. And he said, "What is this slide?" And someone in the back said, "These are the states that have not expanded Medicaid." And he said, "Wrong. These are the states that have decided not to implement Medicare." It was a slide from 35 or 40 years ago. These are the same states that have been reluctant to accept and implement pay schedules for Medicare. So he was saying that it isn't just the Affordable Care Act, and it just isn't President Obama, and it just isn't this, that, and the other thing, that there may be some cultural perspective or historical perspective that goes along in dragging your feet. I would submit to you that if whatever we're looking at in 50 years, whatever health or financial, we probably could put the same slide up, and you'll see from South Dakota or North Dakota on down, a little bit over to Missouri, there will be a reluctance to implement. Now, Missouri is unique. You can see that at least 3 of the states on our borders have expanded Medicaid, and these in the first session, we were really looking at Arkansas. Arkansas expanded the Medicaid program, but did so by allowing people to go to the marketplace to purchase insurance. Iowa expanded Medicaid with a very interesting model in which it incentivized individual behavior. It said that the Medicaid program would pay for your insurance for the first year, but if you didn't use it inappropriately, like go to the emergency room when you shouldn't have, if you met certain kind of targets, if you enrolled in tobacco cessation and weight control programs, then the next year your premiums would be paid for. But if you did not do some of those things, then your premiums, or you would pay a certain percentage of the premium. So the idea is it incentivized good behavior in a way that could bring better population health outcomes. That is a model that has been approached. We have studied it. The state legislature has studied it. Now, currently, The Pennsylvania model, which was the model that our final piece of legislation in the session was about, looked at various components, but one of the most controversial was that if you got Medicaid and it expanded, that you had to enroll and or look for work. And if you did not look for work, you could be kicked off the rolls. Now, the interesting thing is that the Pennsylvania model did not pass through CMS. CMS said that work requirement could not stay. We might be talking work requirements next year in session. Probably not, because the federal government won't okay them. But the important thing to note is that there is still an ongoing debate as to how do we improve the health of Medicaid recipients? How do we incentivize insurance with behaviors? Now, we know that these behaviors take a long time to change, and data suggesting that incentivizing insurance with health outcomes is not very successful. You can't really create population health change by tying it to whether you get insurance or not. I will say this. The federal government has indicated, and President Obama has indicated, that the ACA is probably his most lasting legacy to the country, and he wants every state to have Medicaid expansion by the time he leaves office, which is to say that CMS will make deals with states. So if our state comes up with something, and it may not be approvable right now, i.e. October, but by the end of session, it may actually be approvable. Jobs, incentivizing, more co-pays, etc. The CMS probably will okay anything that is a viable option for expanding Medicaid. Here is our current Medicaid eligibility. The fact is that when I'm out speaking about this, most people don't know about the final item on the other side, that childless adults can never get Medicaid. They just don't get Medicaid. So we got a lot of people who are incredulous about this. They say, well, all these deadbeats are on Medicaid. And you say, one, if you don't have a child, you can't be on Medicaid. Two, do you know that 80% of the uninsured are either a full-time worker themselves or live in a household that has a full-time worker? And they don't understand that as well. People just don't believe that. So the fact is this is our Medicaid program, and this is what our Medicaid program would look like if we had expanded to the federal minimum, which is 138% of poverty. So there are a couple things to note here. First of all, when we talk about this chart right here, in 2005, our Medicaid program was cut, and it had some significant cuts. And there's a high correlation between parents having insurance and their children having insurance. Oftentimes we find that if a mother is kicked off or removed from the rolls, that child, who may be an eligible child, is not enrolled in insurance. So here's this kind of infinite circle we go into. If the parent is insured, then the child is likely to be insured. And the only way to get the child insured is to get the mother insured. So this would do that. The Affordable Care Act and Medicaid expansion would do that by offering insurance up to 138% of poverty through the Medicaid expansion program. If you were above 138%, you could get a subsidy to purchase insurance. So it's really, once you get in the door, you're going to get some assistance of one type or another. Now, here is the federal poverty levels. Most of you probably already know these. These are what is used to determine both eligibility for Medicaid and for the exchange. So here are the exchange subsidies. And by a quirk, the law was written such that the subsidies went to 133%, went to 133% of poverty, yes. And the subsidies for Medicaid expansion would have gone up to 133%, creating this gap of individuals who can't get any health insurance because we did not expand Medicaid. Interesting enough, they're too poor to get assistance to purchase insurance. That's about 300,000 individuals in Missouri are left out in a gap that does not allow for them to get any assistance. I guess, the upside is that they don't have to purchase insurance under the Affordable Care Act, but the downside is they don't get any insurance. And these individuals are people who are most likely to have a job, most likely to be working, most likely to have families that work, and just put them out of reach of traditional Medicaid. And that is where not expanding Medicaid has hurt the most vulnerable in our state. And you say, well, where do these people live? Well, look, the blue, light blue and above, are 8 to 10% of the population. And if you look at that band along the southern part of our state and above the northern part of our state, these are 8 to 10% of the population would have been eligible for the Medicaid expansion program had we expanded it. Now, we have been looking at, and there has been, I don't want to say scare tactics. Some people say they're scare tactics, but let's just talk about what is the impact for these communities and these counties. In most of these cities that are in these counties, one of the major employers is the hospital. The hospital is the employer. Now, if there's kind of a perfect storm going on right now. It used to be that the federal government gave hospitals money to see the uninsured. It's called dish payments. Well, guess what? As part of this law, because everyone's going to have insurance, there are no more dish payments. That's going away next year. Also, many rural hospitals got a designation that gave them bump-up payments. They were called critical care access hospitals, and they got bump-up payments. Those payments are disappearing as well. So at the same time that hospitals would be expecting many of their poor population to have insurance, they're losing the kind of safety net, the fiscal safety net that comes from the federal government. So when we look at these counties here, lots of these people will show up at their local hospitals and they will not have insurance. This law did not change the regulations related to showing up in an emergency room and getting care. So lots of rural hospitals are very fearful that they will be able to stay open because Medicaid expansion did not happen. So we have been doing a little research and talking to hospitals, and you know what the interesting thing is that hospitals never tell you they're about ready to go out of business because they don't want to lose their doctors and nurses and professional staff. So when they do go out of business, it's catastrophic. They're open on Tuesday and they're closed on Wednesday. And so we have talked to a number of groups and said, listen, can we get a map and put things on the map to show where there are hospitals that may be, in the red zone or in the yellow zone. And hospitals don't want to participate in that. They don't want that information out there. You can't blame them. So what some hospitals are thinking is they will go out of business. And other hospitals are thinking they're just going to close their emergency room because it's the emergency room where they have to see people by law. And we're seeing this in other states around the country where hospitals are going out of business and or just closing their EDs or ERs. Now, I think it's interesting that the speaker this morning was talking about hospital consolidation. We're also seeing that in a different way. So rural hospitals are probably going to disappear, and it's not going to be for the fiscal reasons that bigger hospitals are getting bigger, because there is a lot of consolidation going on in the hospital industry, and it's not a case of big hospitals buying rural hospitals. Some rural hospitals are going out of business because they can't be competitive anymore, and this contributes to that. Now, the thing that is of interest from a policy perspective is transportation. Do you know that we've always talked about transportation as an issue, but it always seemed to play second or third fiddle to access or to uninsurance. But now, because more and more people are insured, many of the issues that were further on down the list are now coming to the fore. And one of them, and maybe the top one, is transportation. As larger hospital systems buy smaller hospital systems and move their services to the bigger metropolis, in the end, people are going to have to travel more. The people who can least afford to travel are going to be traveling more. Medicaid, why does Medicaid matter? This is just real quick. Medicaid matters because reductions in uncompensated care, I mentioned that, health systems expansion in states, hospitals in states that have not expanded Medicaid are feeling the burden. Medicaid expansion brings in about $83.6 billion in federal funding, and states choosing not to expand Medicaid will be giving up roughly $88 billion. Here is a chart here that shows in states that have expanded Medicaid and their admissions, and you can see when people have insurance, their admissions are lower. People show up at the emergency room and are admitted less often because they have preventive care, because they begin that process of learning how to use care. Supporters of Medicaid expansion say it's the right thing to do morally. Interestingly enough, the Missouri Foundation for Health just did polling, and we found that the economic argument does not matter. The moral argument in Missouri is the most persuasive argument as to why we should expand Medicaid. It is the right thing to do for families. Hospitals need the money, the economy needs the money, the state budget needs the money. This is cost neutral. It's actually cost positive for the first 3 years, 2 of which we've already lost, but it's relatively cost neutral. The feds won't go back on their promise to pay. There is a great deal, and our state legislators have said this time and time again, they do not trust the federal government to follow through on the commitment. That is why in just about every piece of legislation that came out in the last 2 sessions, there's a sunset phrase at the end that says if the federal government decides not to follow through, then Missouri could back out of expanding the Medicaid program. And health care will enable more people to work. Opponents of it say expansion is too generous, Medicaid is broken, and I think it's important to note here, you've probably heard this if you've been following the debate, there are 2 debates going on. One is Medicaid expansion, and one is Medicaid transformation. They are 2 very different debates. Medicaid expansion is about expanding to people who don't have. Transformation is about how do we get our existing program to work better. And if you've been following the news, you'll see that the Medicaid program or MoHealthNet is besieged with backlogs, people applying and not getting on. There is also some countervailing forces going on that they're reducing staff, they're changing their computer system at the same time. So they have a lot of things going on in addition to possibly expanding Medicaid. So don't get caught up in the trap that Medicaid transformation is Medicaid expansion. They are 2 very different things, and most people think they aren't. The government is too large already, and this will make it impossible to shrink. And these are just the generic arguments that go. What reformers want, people who want to reform the existing Medicaid program, they want more private insurance, not public programs. They want more patient responsibility, cost sharings to the patients, premium increases, incentives for healthy behavior, and some sort of work component. So these are the major components of a kind of reform and or a modified insurance Medicaid expansion program. And they want to use market incentives to keep costs down. So where are we headed? On the delivery system, there is going to be a push for efficiency, transparency, and new business models. We have to address workforce issues. On marketplaces, there's lots of variability in pricing across states. There's even variability within prices within regions. There are lots of issuers or insurance companies that are joining. We're probably going to double. Medicaid expansion, math should trump ideology eventually, that which is to say, will Missouri pass the Medicaid expansion program? I would suspect that at some point in the next 5 years, we will pass it because the math of it will suggest that not doing so is untenable. But this is at odds with the moral argument, which seems to be so strong, especially for single mothers, to pass this because it's the right thing to do. Now, I want to bring that to I guess I don't want to go there yet. Where is the Missouri General Assembly on this? Several bills were followed. Expansion and reform other. We've been looking at other states. Politics has trumped policy in many ways, and what the legislature needs to hear are the stories of real people. Federal expenditures. So how much is this really costing? We paid $13 billion, the federal government paid $13 billion in subsidies to help lower income Americans pay for their premiums. The CBO, or the Congressional Budget Office, actually projected that it would cost $19 billion this year. So it's actually $7 billion less. I would suspect that is due to the variability in different states and how they made the marketplaces well known. I would also say it's probably because the website was so terrible in the first couple months. CBO projected that federal Medicaid spending would be between $320 billion and $335 billion. In the end, it ended up being $302 billion because states, not all states, well, 27 states have not expanded the Medicaid program. The important thing to know about expanded eligibility criteria is when you ask how many people actually went on to Medicaid because of expanded eligibility, it's hard to parse out people who were eligible before and didn't take advantage of it. And because of what the federal government did and because of what groups have done, they've raised the IQ about the Medicaid program. And there were thousands of people who were eligible for Medicaid and who enrolled and got Medicaid. And in many other states where there expanded Medicaid, they were able to take advantage of the Medicaid expansion program. So the point is, it roughly cuts down the middle. Half the people had existing eligibility and half the people were new eligibles. As we move forward, we're probably looking at the number of existing eligibles going down, except children. Children across the state remain under-enrolled because of lack of knowledge, because of parents being unenrolled or not being enrolled, etc. Now, what does this look like by way of cost? You can see right here, the top two are exchange subsidies and Medicaid and CHIP outlays. So the fact is that most of the costs related to the ACA are related to subsidies and or to Medicaid expansion. These bottom ones are tax credits and or the penalty you pay for insurance, and these are projections on what it would cost. So the total cost is significant, but when you think of the cost savings relative to people being uninsured, dish payments, etc., it ends up that the ACA is going to be cost neutral to our federal budget. Now, here's something that is of interest. So I was at a conference not so long ago, and a gentleman stood up and he said, most Americans believe that the American dream is just a dream. That is, the American dream is dead. 59% of the respondents, and this is a national poll, said that the American dream has become impossible for most people to achieve. Now, the interesting thing, and let's go to this next one, confident or not confident that life for our children will be better or has been better than for us. 76% of the respondents said they do not believe their children will do better than them. Now, the American dream, whether it was a reality or not, the American dream was predicated on get a job, get an education, get a job, and you can do better than the generation before. And more Americans are saying that is not the case. Now, as fact of that, we have people in Missouri who went to school, got a job, don't have insurance, have medical debt, and can hardly afford the housing and or transportation that they have. The American dream is not alive for them. The interesting thing from a policy perspective is, for years, we have not been talking about health disparities because of the specter of the American dream. These people just needed to work harder. They needed to plug in. They needed to get a better education. Now, because there is some sort of tacit agreement that maybe the American dream is not alive, we are talking about health disparities in places and in ways that we have never talked about them before. Transportation, health insurance, access, outcomes. We didn't talk about, well, most people in this room talked about them, but outside of that, before the Affordable Care Act came about, if the Missouri Foundation for Health said we'd love to sponsor a day-long talk or a day-long conference, why don't you come? In some small town in Missouri, we'd get no one. No one wanted to hear about this. Now, we go to libraries and Rotary clubs all over the state, and people are talking about health and health care in a way that they weren't 5 years ago, 3 years ago, 2 years ago. So, my last slide is this. I guess it's not my last slide. This is a chart, and I'm not asking anyone to go rally to go camp outside of Wall Street. This is not about getting the one percenters. But this is from the New York Times, and it shows the percentage of inequity with each, and they put them into expansion periods, and it shows how much of the equity or the earnings were based on income or percentage of wealth. And you'll see here that 20% of the income growth in the 1949 to 1953 went to the top 20%. And most of it went to the bottom 10%, or bottom 90%. As you look over to 2009 and 2012, you will see that there is very little growth in the lower sector, or the lowest sectors of the economy. I submit to you that this is part and parcel of that perception that the American dream is dead. It's very hard to incentivize, to inspire students to do better, inspire workers to take on more work, inspire people to get a job if the job doesn't have health insurance and the job doesn't pay well and the job doesn't enable for the purchasing that keeps our economy alive. Now, will Medicaid expansion do that? No. But Medicaid expansion is a step in a direction of creating equity where there's inequity right now. Right now, if you get a job in a small town earning $10 an hour, and that job does not offer insurance, 97% of all employers in Missouri have fewer than 75 employees. Fewer than 50 employees, you do not have to offer insurance through the Affordable Care Act. Most of our small businesses, most of our employees work in small businesses that do not offer insurance, and there is no incentive for them to stay at those jobs from an insurance perspective and sometimes an income perspective. We have to change the incentive structure. Why does health reform matter? Disparities are problems, not costs. Politics and policy are in opposition. The ACA requires dialogue and modification. The American dream depends on good jobs, good wages, good education, and good health. Not one of the above, but all of the above. And finally, behavioral change takes generation, not just months and days. It takes years. And the Affordable Care Act will be measured 20 years from now because it's asking people not to acquire chronic conditions. It's asking people to go to the doctor in the right place at the right time. We won't see cost savings from this law for 20 years from the behavioral perspective. From the institutional perspective, hospitals and insurance, we're already seeing some of those things. This is my contact information and my phone number and my email. If you have a quibble or a question, please feel free to contact me. If you need somebody to present to a group, talk about healthcare and healthcare reform, please give us a call. That said, I'm open to any questions. Yes, sir.
I recall at least publicity of them extending the dish payments. How far did they extend them when they did?
I believe it's this year. This year, at the end of this year, but there's talk that they're going to extend them another year. So the dish payment extension probably will happen because of rural hospitals. So I don't think we will see dish payments disappearing until into 2016. Yes, ma'am. Yes.
So the hospital, I forget the organization that hospitals join.
The Missouri Hospital Association? Yes.
Are they lobbying for Medicaid expansion?
Very actively. They are committed to this. They are committed to this both for their clientele and for patients. Yes.
But they're not making much headway.
Well, it's. I'm not sure that. you can't overestimate the power of just one group. This is a case in which there have to be lots of groups and lots of people putting pressure. MHA, or the Missouri Hospital Association, for the last 2 sessions has been very active in trying to raise the Medicaid expansion quotient or understanding. They have been talking with legislators, but the way that the politics of Missouri is that we have a supermajority of Republicans, and that moving the needle becomes very hard when you don't necessarily need to compromise, or you don't need to, you're working within your own party. And sometimes pendulums swing to the extreme, and some of the extreme positions are not in favor of Medicaid expansion. So there's a lot of work being done, and it's going to take both that grassroots, the stuff that I start off by speaking, by phone calling your legislator locally. I put it this way. In Jefferson City, there are lots of people and lots of groups actively talking about Medicaid expansion, pushing at Medicaid expansion, and trying to get people who don't understand it to understand it. But lots of those people, those legislators, also come home on the weekends, and they don't necessarily hear the same thing from their constituents. And if there is a kind of full circle of pressure that happens, then that will allow many of the people who ran against the Affordable Care Act to actually vote for it when it comes to a vote. Think about it. If you were in a small town in rural Missouri and you ran against the Affordable Care Act and you got elected on the Affordable Care Act, there's not a lot of space for you to say, well, now that I'm elected, I want to support the Affordable Care Act. What you need to be able to say is, I've been hit by the apple or hit by the rock. I see the light. It's good for Missouri. Could we call it something else? And that is the kind of discussion that groups are having in Jefferson City. How can people who ran against it have the cover to vote for it without losing their next election? So it's a very complicated process on both sides. Yes?
Hi, Leslie Ford with Missouri Hospital Association. I'm the Division Vice President for Strategic Quality, so we can visit offline. But I want to thank you, Thomas. Your message is stellar, you're spot on, and I just want to speak anecdotally, but with data and confidence, that what you talk about in the map you showed with Missouri with some of our rural areas, and we sometimes use the term hemorrhaging in their healthcare costs, is very, very real. We have 3 hospitals in the southwest area that have closed or drastically changed services. Sac Osage was a small rural hospital. It is closed now. Missouri Rehab Center is closed. And Ozark Community Hospital in Springfield has drastically reduced their services. All 3 of these are saying this would not have happened had we passed Medicaid expansion. So everything Tom says, spot on. Go back, really advocate at the grassroots level, try and engage these people. It is a tough, tough battle, a critical battle. We need all the help we can get.
5 minutes? Anyone else? Yes, sir.
Has there been any thought of expanding Medicaid by kind of bypassing the legislature?
So actually, there has been some thought. We can't bypass the legislature because of the way the law and the Supreme Court case was written, but there has been some talk about taking it to a statewide ballot initiative. And one of the legislative proposals last year actually called for that. There is a mixed record of ballot initiatives on an issue as complicated as this. It's very hard when you're limited by ballot size to explain what the Medicaid program would or could do. The Missouri Foundation for Health has been involved with tobacco and tobacco tax possible legislation, and when tobacco tax increases go to statewide ballot, they tend to be swallowed up in verbiage, and they're not easily understood. So what you might see is going into a ballot initiative, you might see polling that suggests this thing's a no-brainer, it's passed, and then it loses by 60%. And it's this fundamental disconnect. So there is talk about it. There is a real possibility that it could happen. But by way of actually getting the Medicaid expansion program passed through a ballot initiative, it gives heartburn to lots of people, and should. Anyone else? Yes, sir.
Thomas, there's been and we saw on the map, there are quite a few states that are normally red that have taken sort of an alternative approach to Medicaid expansion, such as Arizona. There was the governor's proposal in Indiana to have premiums with small premiums with Medicaid expansion. How would you characterize the discussion in the legislature as far as for lack of a better phrase, the more moderate to conservative approach to Medicaid expansion? What are some of the ideas?
So some of those ideas were on this slide right here. It has been very active. Let me see, where is that slide? Is it right here? It's been very active. There has been an exploration. So I think of it in two ways. So 2 years ago, it was House Bill 700. And House Bill 700 was going to really change the Medicaid program. It was not going to be a full expansion. It was going to be a partial expansion. And it was going to try to push as many people into the marketplaces as possible. And that was along the Arkansas model. Last year, we saw a willingness to talk about the Iowa model, along with Indiana was not at that time really in play, but the Indiana model, where we might include some sort of premium sharing. The federal government does limit, and the law limits, how much premium can be shared. So it would require a kind of waiver or super waiver from CMS. To answer your question, Jeremy, it's been very active. The state legislature has been looking at all of the surrounding states. They have been trying to pick and choose those things that fit. The biggest hurdle right now is that there has been an unwillingness to have a full expansion. They have been arguing for a partial expansion. For people from 0 to 100%, they would get a certain kind of expansion. And above that, there would be no expansion at all. So what CMS has said is you have to expand to everyone. You can't just pick and choose a couple federal poverty level lines and give it to some people and not give it to everyone. So I think that's the first hurdle we have to overcome, is it's a full expansion. Then working out the details of what the expansion looks like. Last year I would have said it would look very much like Iowa. I thought Iowa was the model that we were aiming towards. As we move into this session, I can't really tell you what state we're looking to as the guidepost. Anyone else? Thank you very much. Have a great day.